Hello and welcome to the NorthShore Outcomes Research Seminar and the fifth in our COVID-19 research series. Today we are privileged to have Dr. David Drew, who will be joining us to present his team's research on the COVID-19 symptom app, real-time epidemiology using the smartphone app during a global pandemic. We are also honored to be joined by an expert panel, including Dr. Erica Warner, Dr. Ajoa Anyana-Yeboah, and Dr. From Massachusetts General Hospital and the Harvard Medical School, and Dr. Alan Sanders from NorthShore. So I'd like to start off by thanking our first responders and everyone working on the front lines during this pandemic, to the NorthShore leadership, to the Outcomes Research Network, and Dr. Eligman, the director, and all the program directors. And I'd like to introduce the co-facilitators today, Francesca Carlock, who is a research coordinator in Outcomes Research and Family Medicine, and Rachel Brewington, who is our administrative assistant and has been a wonderful contributor to this seminar series. So that for those of you who are new to the Outcomes Research Network, it was structured with key academic leadership to support and catalyze research across the NorthShore University Health System, our training programs, and across our Clinical and Translational Science Award affiliates, the Institute for Translational Medicine. And the goals are to enable uniform community access to care that is effective, efficient, and equitable, enrich the practice of medicine, and support key strategic clinical, quality, and operational decision-making. The objectives for the seminar series are really the flourishing of principal investigators. We want to bring investigators together outside of the silos and begin to incubate and catalyze research. We also want to disseminate research activities and resources between investigators and promote a culture of collaboration and team science. And we want to bridge people together, not only across Chicagoland, but across the country. So we're really committed to delivering outcomes research that demonstrates improved patient population health outcomes and equity. So next slide, please.
Thank you, Dr. David, and hello, everyone. In today's webinar, all attendees will be muted with the exception of our panelists and speakers. However, there will be some opportunity for interaction. If you have any questions or comments at any point during the presentation or the Incubator Hub discussion, please submit your communication by using the chat function as noted by the blue arrow on the screen. If you are on a computer, you can access this icon by hovering your mouse over the bottom of your Zoom screen. Please give special attention to the audience of your message before you submit it. As you can see on the image to the right, you can choose to message either the panelists and speakers, this will include myself, or you can choose to message everyone on the webinar. If you're experiencing any technical difficulties, please let me know by messaging all panelists, and I will assist you the best that I can. I'm going to hand it back over to Dr. David, who will now go over the agenda for today. Next slide, please.
Thank you, Francesca. So just an overview of the agenda for today. After the introduction, Dr. Drew is going to give his lecture. This will run until 3:40. Then we'll be taking comments and questions from the comment section for a Q&A session after that. And then following the Q&A, we'll have the Incubator Hub expert panel discussion with Dr. Sanders, Warner, and Anyana-Yeboah. And then we'll finish up with some closing remarks. Next slide, please. So our speaker today is Dr. David Drew, who is the Director of Biobanking with the Clinical and Translational Epidemiology Unit at the Massachusetts General Hospital. And he's a co-investigator in the COPE Consortium. So, without further ado, I would like to hand it off to Dr. Drew to start off the presentation.
Thank you, Dr. David. I appreciate the opportunity to be here to talk a little bit about our COVID symptom study, which the NorthShore Genomic Health Initiative is a part of and has helped us really get this off the ground in the US. And so if you go to the next slide, please. I'll just start with a brief background on COVID-19. For those who are not familiar, but I imagine everyone's quite familiar at this stage of 2020, COVID-19 is caused by the severe acute respiratory syndrome, coronavirus, or SARS-CoV-2. There's a multitude of symptomatic presentation for this disease, but there's also a high level of asymptomatic carriage among the general population. The disease is associated with multiple outcomes, including the development of acute respiratory distress syndrome, or ARDS, which is accompanied by a cytokine storm and in many cases is fatal. These numbers are unfortunately out of date already. So when putting this slide set together last week, the global case count was around 51 million, but today that case count is actually exceeding 54 million, with an additional million cases in the United States. And this has been accompanied by a global death rate of about 1.3 million people now. And this is, many people have said that we're in the second or the third wave. And if you look at the case rate in the US, yes, there are peaks and valleys, but we have never really come over the first wave or had real resolution of the pandemic from the beginning. And that can be really seen as evidenced here that even over a 4-week period, there's been emergence of hotspots, and particularly in your area as well, and across the Midwest, have we started to see even more case counts compared to what we had classically seen earlier on in the pandemic, where the coastlines were really impacted drastically. And next slide, please. So in terms of the strategies by which we might be able to beat COVID-19 and return to whatever normal may be defined by, there are several requirements that need to be met, including the increased availability of rapid and accurate testing. We have made strides in this area. The management and broad availability of supplies, including personal protective equipment, comprehensive contact tracing. Additional states now are bringing on mobile phone applications and technology to help track contact tracing. And then universal mask mandates and consistent social distancing recommendations across the United States and abroad. But the last 2 bullet points are something that we've actually contributed to as a part of the COPE Consortium and the COVID Symptom Study. And that's to the real-time monitoring of cases and symptom activity across populations, and then also coming up with collaborative data sharing and integration so that we can really combine resources as we're trying to rapidly address this evolving pandemic. And all of this is really required until wide-scale testing, which we've made improvements in this area since the beginning of the pandemic, or antiviral medicines or vaccines are available. And the last few weeks has been really inundated with some positive news in vaccine development, and we hope that the track continues there. Next slide, please. So how did we address this? Well, we launched the COVID Symptom Study in late March in the United Kingdom on March 24th and in the United States on March 31st. The COVID Symptom Study is a mobile phone application that's designed to interact with the individual for less than a minute a day and really just track prospectively the emergence of symptoms in COVID-19 among populations, where we encourage individuals to use this app daily, record how they're feeling, even when they don't have symptoms. But when they do experience symptoms, they can provide us information on the emergence of those symptoms, empowering prospective analyses and longitudinal analyses of symptomatic burden presentation across the population. If individuals are tested, they also are given the opportunity to upload those test results, and users of the app are actually returned data in real time based on those individuals with the prevalence of symptoms among their communities based on their zip code. Next slide, please. So how did we stand this up in such a short period of time? Well, we have partnered with collaborators at King's College of London and a spin-out digital health company called Zoe Global Limited. And our original goal, and still is a continuing goal, is to look at precision medicine and specifically precision dietary interventions and personalized responses to foods to better understand human health. And because we had gone through the elaborate process of getting this digital technology approved by the institutional review boards at Massachusetts General Hospital and ethics boards at King's College of London, we were able to rapidly develop this tool to launch among a general population in a way that was safe, secure, and met digital health standards here in the US and the more rigorous GPDR standards in the United Kingdom. And we were able to take that digital backbone and lay this survey for COVID-19 on top of it. Next slide, please. So there were obviously some challenges with this. And one of the things that we knew we would want to do is to approach existing research studies and cohort studies that have really drastically impacted our epidemiologic knowledge of a lot of different disorders, to be able to link data in the app in a real-time fashion back to those individuals, especially as we need to consider from a research perspective the long-term consequences of COVID-19 and how that may impact other health outcomes. So within the app, we have standard terms of use and privacy policies, which you typically might see in an app. But we also nested in a research consent arm that allows us to take individuals who identify with a research study and provide specific research consent to link the data collected in the app and share that with the individual cohort investigators who recruited them to use this study. And this also overlaps the way that we ask questions in the app. And we ask basic demographic baseline information, race and ethnicity, sex, gender identities. We ask for zip code, but no further location data. We do not track location data from your phone. It's only from self-provided zip codes. And then we ask some general questions about your health, looking for comorbid conditions, looking for other medications that you might use. And we also have asked if individuals are part of the healthcare worker community. And then daily, we ask individuals how they're feeling and ask them for updates to any COVID-19 testing they've received, and if they've sought treatment for COVID-19 when they weren't feeling well, to give us some information on that as well. And then weekly, and then sometimes a little more frequently, we'll also ask about isolation and how much interaction they've had with others and what kind of exposure risk they've had. So next slide, please. And shortly after we launched the app, we also launched it in Spanish, which we saw as a major barrier to use of this app more broadly. And we've offered this to individuals who have their phone settings in Spanish, are able to go to the app stores and actually download the Spanish specific app, which has really helped us increase the use among a very vulnerable population. Next slide. So at the same time, we knew that we couldn't exist in a silo and we couldn't try to attempt this science by ourselves. And what we thought to do was, as cancer epidemiologists, when there's not a pandemic, we thought we could use the network of epidemiologic cohorts that exist to identify patients, especially hard to reach populations, to use this app and expand our geographic coverage of who was actually using the app. So we quickly established the Coronavirus Pandemic Epidemiology Consortium, or the COPE Consortium. The full details of what we were trying to achieve have been published in Cancer Epidemiology, Biomarkers and Prevention if you want to go read some more. But we also have a website that you can find at mongeninstitute.org/COPE Consortium. And here we also developed an IRB toolkit. We provide links to download the app and frequently asked questions for investigators. So if you have a cohort that you would like to enroll and bring on the app, especially as we enter this third phase of the pandemic and the dangerous winter phase of COVID-19, please feel free to visit our website and reach out to us. Next slide. So we've had many cohorts sign on from the very beginning, and we're constantly adding new cohorts to the COPE Consortium. You'll see the NorthShore Genomic Health Initiative is highlighted here. There are approximately 350 patients. These numbers are a little old. This was at early November, who have been using the app semi-regularly, but we have a broad representation across different cohort studies in the United States. Next slide, please. And we're not the only one who has developed a consortium, and in fact, we have become part of the Coronavirus Census Collective, which is an international consortium which has been designed to bring together different investigators who have tools that are collecting similar information. And when you think about the gigantic web of what has been happening in terms of digital health response to COVID-19, there's a lot of different approaches that have been taken. And we're not the only symptom reporting app that's on the market that anyone can download and use to track or to promote use among certain populations, but we are in touch with some of these users, like How We Feel or the COVID Near You website-based tool, and we have committed to working together to try to address this pandemic now and in the future. Next slide. So as an example of this, the COPE Consortium has really led to a vast array of pretty rapid insights into COVID-19. And I'll run through a few of our publications, but then really focus on some of our unpublished work in race and ethnicity and COVID risk. But I will also touch on how we can predict hotspots, frontline healthcare workers and the risk that they see, and also risk among vulnerable cancer patients. Next slide. So this really started within the first week of app usage in the United Kingdom, and then the subsequent week in the United States. We were able to start to look at symptomatic burden across the country in the United Kingdom And what we found was that symptomatic burden was relatively high, but it was difficult to disentangle which symptoms were sensitive for COVID-19. But what we did notice was if we started to look at individual symptoms like fatigue and cough, we saw rapid or widespread prevalence of these symptoms across the United Kingdom. But when you started to put in some of these less prevalent symptoms like diarrhea or anosmia or the loss of taste and smell or fever, and you considered complex symptom presentation where you had either fatigue and or cough, and then the addition of diarrhea, anosmia, or fever, which is what is in this complex symptoms map, we actually found that the regions that had high prevalence of complex symptoms were those that were more likely to overlap with regions showing higher COVID positivity rates. And this made us think maybe there was a way to use symptomatic presentation to predict COVID-19 positivity, especially in the absence of widespread testing very early on. Next slide, please. So our collaborators in the United Kingdom had developed a prediction algorithm to predict COVID-19 using a symptom-based score. So our work was one of the first groups to demonstrate that the loss of smell or anosmia was highly predictive of COVID-19 positivity. Now, not every COVID-19 positive patient is experiencing loss of smell, but it seemed to be more sensitive in distinguishing COVID-19 positive patients from COVID-19 negative patients than other symptomatic presentations of the disease. And this has been subsequently confirmed by other research groups and independent data sets. Next slide, please. So we used that prediction model to try to understand if you could use prediction-based modeling of symptoms to identify hot spots in real time ahead of public health reporting. So in this case example, we see Wales and different regions in Wales, and we see this initial peak around April 2nd. And early on in the pandemic, you can probably recall that there were periods of time where everyone thought we might be clear as testing rates started going down, or testing rates were going up, but test positivity was going down, that perhaps you could start to release lockdown measures and we didn't need to stay in these extreme measures. And in reality, if we followed public health testing reporting, we could have been fooled into thinking that we were in the all clear. As we see in panel A, there are these regions that are dark red that had not yet been tested, but had high symptomatic presentation and a high rate of predicted COVID based on those reporting symptoms in the app. And what we see is 5 to 7 days later, we see another peak in incidence in public health reporting. And then similarly, that starts to drop off again, but there are several regions which are still hot, so to speak, in terms of symptomatic presentation that again subsequently resulted in another peak in positive test reporting about 5 to 7 days later. So we really saw this as proof of principle that symptom-based reporting had the capacity to find earlier hotspot identification than waiting for test results to roll in, especially when testing was limited at the time. Next slide, please. In addition, we've used this app data to identify and quantify the risks associated with being a healthcare worker during this pandemic. And early on, what we were able to establish is that frontline healthcare workers were 11 times more likely to test COVID positive compared to the general public. And we found increased risks among those who reported inadequate PPE availability or reuse of PPE, and especially among those who were reporting direct patient contact with suspected COVID-19 positive patients. And this was published in The Lancet earlier this year. Next slide, please. In addition, we were able to look at some of our cancer patient population that was within the app and found that, participants were more likely to be at risk for COVID-19 if they were living with cancer, and especially those who were receiving chemotherapy or immunotherapy actively at the time of using the app. In addition, in subset analyses, we found that the risks were even higher among the elderly population and among men. And these individuals were more likely to be hospitalized as well. Next slide, please. And we also, from the perspective of a person who does aspirin chemo prevention research when there isn't a pandemic on, there was widespread concern when an editorial was published in The Lancet that ACE2 could be increased by ibuprofen use, and this caused some widespread concern about the use of NSAIDs when the French health minister actually tweeted that individuals should not use NSAIDs because it would potentially increase your risk for COVID-19. This prompted responses from the FDA and the EMA, and you can imagine the broad classification of NSAIDs being potentially dangerous in a pandemic could have ripple effects for people who rely on these drugs for chronic pain management or anti-inflammatory effects, or those who are using it for secondary or primary prevention of cardiovascular disease or cancer. So we thought, this is one of our research interests. Let's make sure to look into this in our app. And if you go to the next slide, please. We actually found that if you look anecdotally at the association of NSAIDs with COVID-19 risk, there appears to be an increased risk. But we find that this is primarily confounded by comorbid conditions at baseline that may confound the indication for use of NSAIDs regularly. After we adjust for that, we see an attenuation of the risk. And when we further adjust for those who present with symptoms of COVID-19 at baseline, taking away those individuals who might report NSAID use around treatment of fever or other COVID-19 symptoms, we see that this really goes away. But importantly, we found no specific risk among individuals who reported aspirin use compared to ibuprofen or other NSAIDs. Next slide, please. So for the rest of the talk, I'll focus on some of our unpublished work around a really important public health issue. And many of us are aware now that COVID-19 is disproportionately impacting racial and ethnic minority populations across the United States. And we, very early on in the pandemic, this was raised as a concern for obvious reasons. And we thought we need to really quantify what is impacting these communities. And many hypotheses were being thrown out at the very beginning to say that it's the higher comorbidity condition rate among these populations, it's different factors. And I'm going to walk you through some slides that actually show that while that explains part of the story, what we also find is that there are structural and systemic factors that are really impacting the risk of COVID-19 among these communities. So next slide, please. So in our app data, we do find that individuals of racial and ethnic minority groups, including the Hispanic population, as well as the Black and Asian populations, or those identifying as more than one or other races, were at increased risk for COVID-19. When we adjust for comorbid conditions, we only see a slight attenuation in the effect or of the risk estimate among these populations for COVID-19. Further adjusting for the propensity to receive testing attenuated the estimates even further, but we still see significant risk among these populations, which was concerning for us. So we started to do a deeper dive to try to understand the systemic factors that may be influencing this risk. Next slide, please. So we thought to examine, based on zip codes that the participants provided, the impact of structural inequities on the minority population and their risk of COVID-19. And what we found was that population density, median household income, education, essential work, household size, and insurance rates were associated with COVID-19 risk, especially among racial and ethnic minority subgroups. Next slide, please. So independently, we looked at the factors of structural inequity and how they could predict COVID-19 risk. And we found that they were strongly associated with, each of these factors was independently strongly associated with the risk for COVID-19. And on the next slide, we decided to develop a structural inequity score as a way to identify communities where risk for COVID-19 would be higher. And in addition to symptom-based reporting, we may actually be able to identify communities earlier that need more resources, need greater testing, need greater public health education to try to reduce the risk of COVID-19. And what we find in the United States is that those individuals that there is a stepwise progression of risk associated risk of COVID-19 associated with living in a more deprived community, according to our structural inequity score. This US-based score is similar to what the index of multiple deprivation is in the United Kingdom. We are working on improving this score to make it more directly related to the IMD in the United Kingdom. But when we looked at both the IMD in the United Kingdom and our own structural inequity score within the US, we found very similar results for racial and ethnic minority subgroups, with the exception that there are some additional subgroups in the United Kingdom that we do not capture using our standard race and ethnicity questions in the United States, where those risks were seen among the United Kingdom population. Next slide, please. So in addition, we started to look at the subgroups, especially within frontline healthcare workers, given the association of essential work and in terms of the structural inequities. We saw that the healthcare work practice site was very strongly associated with COVID-19 risk among healthcare workers. And it also seemed to track with those who had PPE reuse or inadequate PPE that really increased the burden among healthcare workers. And in the next phase of this, we actually looked to see if there were any race and ethnicity associations among among healthcare workers. So in the next slide, we found that frontline healthcare workers who were of racial and ethnic minorities found that their risk was even higher compared to their white counterparts in the business. And part of this is mediated by the effect of the work environment, but also in access to PPE. And we found that this was a significant public health concern, especially for those individuals who are essential workers coming from these communities. On the next slide. So I'll just sort of wrap up that there are some strengths and limitations to our approach that we are obviously aware of. By developing a mobile phone application, we were able to develop a large prospectively collected longitudinal epidemiology data set in real time. And being able to nest this within ongoing cohort studies has really enabled us to improve the diversity of our participant base, but also will allow us to pair that data with other long-term collected data, and also going forward be able to pair that and understand the effect of COVID-19 on other health burden. It also provides an adaptable survey platform. It allowed us the opportunity to change questions as our understanding of the pandemic evolved over the last year. We were able to add questions, change the way we asked questions, add supplemental diet questionnaires, add different factors within that digital backbone that has really empowered our approach and has allowed us to better collaborate with people around us, both in the COPE consortium, and adapt to asking questions in a similar fashion to other digital health tools so that we may better pair up our data in the long term. The other strength is that we were able to launch this in multiple countries. Not only is it live in the United Kingdom and the US, we've also launched this in Sweden, where they've had their own unique approach to the pandemic, which has also led to different public health problems for them, but they are similarly able to collect data on their citizens there. In terms of limitations, we know there are barriers to study access that are inherent in someone using a smartphone application, both in having access to smartphone technology and the internet to be able to access our tool, but also that people understand that this tool exists and can be used and why we're using it, and how to differentiate that from contact tracing apps. Because what we have found in informal polling of users is that one of the biggest concerns to people using this app from the very get-go was that it was getting confused with contact tracing apps. And many people don't feel necessarily as comfortable collecting data passively. So when we really had a concerted effort to make it clear that the COVID Symptom Study was only providing data, or was only collecting data that was provided actively. And then lastly, we've really had to balance the resolution of data capture and how many questions we ask at the expense of participant burden and survey length. We really have aimed to collect a very efficient questionnaire that gets us the information that we need, but really takes participants less than a minute a day to fill out. Next slide, please. So this has empowered a lot of different scientific approaches. In the long term, we hope to link this to long-term cohort studies and databases, including genomic health data like that is being collected at NorthShore. We would like to validate in other symptom surveillance studies. We've seen other groups take our data and use it as validation for them, and we are working to actively validate our approaches and our prediction modeling in other data sets that are out there. We, as cancer researchers and longitudinal cancer researchers, we are hoping to ask supplemental detailed cancer questions to better understand the impact of COVID-19 on factors like cancer screening, which Erica can definitely speak to in the incubator session. And then also working to develop targeted recruitment in local communities disproportionately impacted by COVID. And this is an ongoing effort, and we really are thinking how we can get this implemented among those populations that badly need it. Next slide, please. So we'll leave with a plug, basically, that how can you help? We've really relied on citizen scientists to download the app and provide us with data in real time and to use this app regularly. We ask people to log how they're feeling every day. They get a push notification to remind them to log their symptoms every day, even if they're feeling well, which really empowers us to have a smart, a clean baseline for when we do our prospective analyses to understand what things are predicting risk. We've had some great partners across the research and lay communities, patient advocacy groups, including Stand Up to Cancer, that have really helped us get out the message around this app. And what we really ask is that even if you don't use this app yourself, that you perhaps encourage individuals who are among high-risk groups like healthcare workers, the elderly, first responders, or essential workers to use the app so we can better understand the impact of COVID-19 among these disproportionately impacted communities and identify ways in which we can help. And we really hope that this infrastructure that we're creating, while we hope that there is not another pandemic, what we're learning here is that we have an infrastructure that could be applied rapidly should we be faced with another pandemic in the future. Next slide, please. So if you'd like to follow along with our real-time updates, the COVID Symptom Study has a website. It's called covid.joeandzoe.com. There are interactive maps to show where reports are coming in from across the US or in the United Kingdom. We also update our research progress there so you can follow along and learn about new publications that have come out, including preprints. And then we also have a portal here. Sorry, one last. We also have a portal that allows individuals to sign up for future research studies. So if there are future research studies where you're looking for individuals who have rich data collected on them for a longitudinal period, we may be able to partner to help funnel individuals into those studies. So if you're doing a serum antibody test or a vaccine trial, or you just have need for reaching these patients, we do have that mechanism at our hands that we are willing to collaborate on and try to implement so we can better improve our understanding of this disease. Next slide, please. So I'll leave it with saying that I'm here presenting on behalf of a very large collaborative research team at Massachusetts General Hospital and at many of our other partnering institutions. But I have to acknowledge Andrew Chan, who is the lead USPI. Long Nguyen and I are co-investigators on this study and both junior faculty at MGH. Both of us have been really working hard to get this data into the hands of our collaborators and our research team here to try to disseminate results as fast as we can, in addition to our collaborative team in the United Kingdom at King's College of London. But the results that I specifically spoke about today, there are several people who need to be acknowledged, and Wenji Ma, who led our cancer work, Erica Warner, and Ajwa and Chanhan Lo are also people who have been working with us very closely on the race and ethnicity paper, and Chanhan has actually been leading trying to get this published. And then lastly, I'd like to thank Sean David for the invitation to speak to you all today. This seems like a really great forum, and I'm excited to get talking in the incubator session. But also, we really need to thank those members of the COPE Consortium, for which the NorthShore Genomic Health Initiative and Sean have really been a great partner for us to really expand the use of this app across Chicagoland. And we really appreciate the role of our funding sponsors, including the AGA, the NIH, and the Massachusetts Consortium for Pathogen Readiness. There's a few places where you can grab real-time updates. You could follow me on Twitter, follow the CTU on Twitter, or Andy, or Long. Erica and Ajwa are also on Twitter, so I think you could follow them. So I think that's it. Happy to take some questions.
Thank you so much, Dr. Drew. The COPE Consortium is a remarkable feat to develop and translate such high-impact work so rapidly during the pandemic. At this time, we can take a few questions from our listeners. As stated earlier, please input any questions into the chat box by addressing it to panelists and attendees so everyone can be involved. If all questions are not addressed, please feel free to contact Dr. Drew at his email shown on the screen. I'll give everyone a moment to enter their questions. Thank you.
Thank you, Dr. Drew. That was a brilliant presentation, extraordinary work. So,
Thanks, Sean.
okay. So we have a couple of questions so far in the comments. I'll go ahead. So one is from Sarah Bolonsky. Are you working with the Stanford study, which is also tracking symptoms?
So we are working with Stanford investigators because we had an existing collaboration in the PREDICT study, and they are using this app for what I know. There may be additional COVID symptom studies that I'm not aware of or that we are peripherally, I'm not exactly sure which one they're referring to. I know that there were individuals at Stanford who were also involved in the How We Feel app, and we are tied in with that group as well. And that app is very similar to ours, has been broadly implemented in the US, has reached different pockets of geography. I know they had like a partnership with the state of Connecticut, for example, to get that app out. And then it had some pockets of use in Colorado, but also some pretty good use in California, where we also see similarly good use. Their group is led by someone from Pinterest and then also Feng Zhang at MIT. So we connected with Feng pretty early to make sure that we were on the same page. And we did take an effort to make sure that our questions were overlapping so that we would be able to combine forces as we were developing the data sets.
Good. We also have a question from Dr. Anthony Solomonides. Has there been any confusion of the symptom app with contact tracing and surveillance?
There certainly has. We actually changed the name of the app. Originally, the app was called the COVID Symptom Tracker. And so if you are looking for publications, you will see that it's referred to as the COVID Symptom Tracker very early on. And the overwhelming feedback that we got was that individuals didn't trust using a tracking app, a contact tracing app. They didn't like the idea that your phone would know where you were and who you came into contact with. And there was a lot of concern around that. And I actually spoke at a tech summit that was specifically focused on patient surveillance and privacy. And one of the things that we took a lot of time with at the beginning and designed this app specifically to try to maintain a high level of individual privacy. And it's the reason why we ask things like zip code and don't get location from the app. It's the reason why we don't ask them to provide a lot of nitty-gritty details on their health as well. So we've had a lot of messaging around that to try to distinguish the use of this tool. That usually comes in the form of the recruitment letters, and the website is kind of designed to highlight those differences, that it's not a contact tracing app, that it doesn't follow your location. But there is definitely a concern and confusion, which is why we've implemented some of these changes and try to be very clear and transparent in what the app is doing.
Thank you. I encourage other questions as well for the comment section. Please use that section for the questions. I have a question that's related to that. So how are public health authorities using the real-time symptom modeling that you presented earlier, or is that something that you expect to happen in the future?
Yeah, so in the United Kingdom, the NHS in the United Kingdom is actually using the app to help identify potential emerging hotspots and where resources are needed. There's actually a paper that was just accepted by our team in Lancet Public Health. There may be a preprint available. I know there's a preprint available online. I don't know if the most recent version is up yet, because this was literally Friday, I think, that we got the acceptance. But that actually details how we are doing this hotspot modeling and the sensitivity of that hotspot modeling for the NHS. It's been very challenging to reach public health authorities in the US to use this tool because we have this decentralized healthcare system. I'll say the best example of where this has been used moderately effectively in real time is in Texas. So we had a partnership with the Texas School of Public Health, or UT Public Health, and we were able to get them data in real time early on, which they did start to use to identify pockets of county level hotspots to kind of understand where to get a grasp on what was happening in their state. We have approached other states to try to get onto that, into that playing field to help provide that data. But at this stage, the use by public health authorities has been pretty low. We hope that it'll get higher, but it's been primarily academic research and the partnerships that we have among the consortium in the US that has really empowered some of the most useful aspects of this data.
Thank you. All right, we have another question from Omar Nelson. How do you control for false negatives and false positives in your study? How does this affect your overall study? I think that's referring to testing. Yeah,
that's a great question. So we do rely on, it is self-reported data. We did do a validation study where we asked individuals to upload their testing results so we could validate what individuals were reporting in the app versus what they actually had received. We had concerns that maybe testing results may not be very well interpreted and the differences between serum testing versus qPCR testing. And what we found was actually the rate of the positive rate in terms of the true positive of where they said they were positive and the results came in was very, very concordant. So we are very confident in the self-reporting that we get. False positives and false negatives from testing rates that are inherent in the test, we can't do much about that other than potentially handle it in the analysis. So things that we have tried to do is in the inverse probability weighting that we do apply, that does help understand the impact of the test on the risk estimates that we're seeing, on the impact of access to testing and who might get a test, which we help makes those estimates more sensitive, but ultimately we are at the mercy of how sensitive the individual tests actually are.
Thank you. All right, are there any other questions? Please submit them now to the comments section. Give it a little bit and then, okay. All right. So also as we move to the experts panel, feel free to introduce comments that we can pose to the expert panelists going forward. All right, thank you, Francesca.
Sure.
And
I was just going to interject. So that looks like that's all the time that we have for questions. Please feel free to insert anything additional into the chat box for our presenters to review, as Sean said. I will now hand it over to Dr. David, who will introduce our expert panelists and for the Incubator Hub panel discussion. Next slide, please.
Thank you very much. So for our next segment, we're excited to introduce our three expert panelists who will provide more insights into the implications of the work presented. First, Dr. Erica Warner is an assistant professor at Harvard Medical School in the Division of Medicine. And Dr. Ajoa Ayani-Yaboa is a gastroenterologist and instructor of medicine at Harvard Medical School. Dr. Alan Sanders is director of the Behavioral Genetics Unit at NorthShore. And we're all excited that you're here, and all three of them are very robust, prolific researchers. So let's go ahead and go to the next slide. Okay, so in reflection of the really great presentation that Dr. Drew gave today, there's 4 questions that we'd like to pose to the expert panel. The first of which is being what would the implications of this work have? What do they have on health equity? And then we also want to explore the impact on healthcare dissemination, implementation, policy, and future translational research directions. So to the panel, to all of you actually, your thoughts about the implications for health equity of the work that Dr. Drew presented.
So I can start in talking about health equity. So the data around race and ethnicity that we saw with the research really shows how the community and individual level factors really influence downstream health outcomes in COVID-19 as well as in other diseases. So the upstream determinants of health like education, insurance status, policy, racism, discrimination, how all of those factors lead to midstream determinants like in COVID-19, which are access to PPE and masks, COVID-19 testing and access to healthcare. And all of these factors lead to downstream outcomes in terms of disproportionate number of cases, hospitalizations, and death, particularly for minority communities. I think in terms of the app data and its ability to identify hotspots early and really help to reach hard to reach populations, I think for equity, it can really help to identify hotspots, but really use that data to find where to distribute PPE, where to make sure that we're doing enough testing and really get to populations that need it most.
Absolutely, thank you. Yeah, the results of the structural effects on COVID-19 positivity were really striking, and so thank you. Any Dr. Warner, Dr. Drew, Dr. Sanders?
Sure, I'll jump in. I totally agree with what's been said. I think that as mentioned, the app has the potential to reach people in a different, potentially broader way than traditional epidemiological research studies when we're trying to, recruit people in person through advertisements, et cetera. I mean, it's a pretty low lift required for participants in order to be in the study. And, there's some evidence suggesting that, smartphone or phone access to the internet is more prolific than, say, desktop computer access. So I think that definitely has benefits in terms of who we're reaching and who we're including in research. One of the findings that Dr. Drew highlighted was, both the paper that was looking at structural factors and racial disparities in COVID-19, but also we looked at it in the paper on healthcare workers. We were looking at healthcare workers, and we found that, among healthcare workers, there were racial and ethnic disparities where we found, greater risk of COVID-19 among minority healthcare workers. And some of that was driven by two factors. One was where people were working and the availability of personal protective equipment. And so I think, trying to do a occupational health study on COVID-19 probably would have been very difficult, but because of the uptake of the app, we were able to answer this really important question about occupational exposures, and also highlight, a specific population, both in terms of racial and ethnic minorities, but also location. So, nursing homes, skilled facilities, not hospitals that are in high need of additional resources.
Thank you. Yeah.
I found myself wondering a little bit, this is partly health equity, but partly healthcare dissemination and implementation. If some of these differences might start to be seen with things like vaccination rates. I'm wondering, Dr. Drew, are you guys planning to have, besides the individual vaccine status, probably by the surveys, enter into modeling like variation in vaccination rates, perhaps it's too fluctuating, perhaps it's too uncertain of a target, but there might be differences regionally and also in some of the groups that you're finding the disparities.
Yeah, definitely. I think we are, we have plans to track vaccination status as best as we can going forward, especially as a vaccine is made more widely available. We have recently discussed ways that we might be able to even preemptively understand behavior in certain communities as to receptiveness of a vaccine, and if one was available, what factors might influence the likelihood to receive one. So it is something that's on the forefront of our mind. We just don't have the data yet because we don't have the vaccine yet as well. But it is something that we definitely are keeping an eye on and working to establish an infrastructure to capture that data. I'd also say, just to add on to kind of what Erica was saying, I think early on, and I didn't show the baseline demographic data here, but the baseline demographic data supported a lot of the initial hypothesis that many people were throwing out, that racial and ethnic minority groups they had higher comorbidity condition rates and therefore were at higher risk for COVID-19. And what we saw is, yes, there was higher comorbidity rates, but when we adjust for comorbidity rates, and it was very striking how limited that mediated the risk of COVID-19. In our mediation analysis, this was not the overwhelming factor that was influencing individual COVID-19 risks. Instead, it was that structural inequity and systemic barriers and systemic racism, frankly, that was leading to the risk among these populations. So it's very concerning that I think we do have to make sure that we break the mold of preconceived notions as to what may be a social determinant of health, to understand exactly what is influencing the risk of COVID-19, especially when something like this is moving so rapidly. We can miss so much so quickly.
And just to build on that, in terms of the comorbid conditions, it's so difficult when you think about the social determinants of health, because things are so closely interwoven. So these same structural determinants impact, the likelihood that you have some like obesity and diabetes and so forth, which impact COVID-19. So it's just all so deeply interwoven together as well when we think about all this.
Absolutely, and just concerns about increasing disparities with cancer screening and other preventive services that are downstream from these factors. We know of several anecdotes across Chicago of people not getting their chemotherapy for various reasons, and but anyway, so you brought up earlier the idea that perhaps these data could help some targeted interventions to get the PPE out, to do more focused neighborhood level testing and things of that nature. Are you optimistic that this will be applied, that more geo-tracking and tracking of hotspots will be taken up by any of the state public health authorities? Any of you?
I hope so.
Yeah.
I think the likelihood for that to succeed really depends on finding the appropriate partners and community level partners that can help us be movers and shakers to make that happen.
Mm-hmm.
I did want to follow up a little question on that. I heard the explanation in your talk about, the consideration of the geolocation, but kind of ruling that out because, maybe the intrusiveness and such. How did the debate go when you guys were thinking this through, as far as perhaps making that an optional aspect?
Yeah, it didn't go that far. We thought very early on that it breached into an area of data security that we weren't comfortable as a primary academic institution establishing a research tool in real time. We felt that it was more important to make sure that we had a secure backbone, digital backbone, that allowed us to get that tool out rather than doing something quickly and potentially opening up some vulnerabilities to that data. And what we it has not really come back up much, other than that because there has been success in contact tracing apps, that individuals on the team have said, maybe we really should revisit this conversation. And what we've really gotten from some formal and more informal polling of the users is that one of the reasons why they use it every day is that they aren't being tracked. And what we've learned from community partners, so for example, we really approached the Boston first responders. One of the biggest things holding back the city of Boston or the unions that were representing firefighters and police officers from using this was that there was still confusion about potential tracing of the mobile device itself. So it's an area that we have decided we haven't really wanted to venture into because there's so many data concerns and security concerns that need to be there. I'll tell you, as a part of other conversations we've had with external users, like Google and Apple combined to make a contact tracing app that they were able to use their data structure. But talking to the lead designer on the security for how they get that geocaching of where people are, it's highly complex and something that was beyond our depth as an academic research institution to implement without finding a corporate partner like a Google or an Apple who can really ensure the integrity of that security.
Thank you. Yeah, because cell phones are things that can easily be tracked, but to link it to this in some way, I can see how that would raise a lot of concerns. So I think
allows us to keep this more de-identified. Ultimately, the data really stays more de-identified at the end of the day. We have very minimal PHI that's associated with each individual person.
Absolutely, I think how this was handled by COPE was really effective in kind of taking that issue away. So on to the next question. There's a lot of movement toward telehealth and mobile health. What are your thoughts, any of you, about healthcare dissemination and implementation using the symptom app with healthcare, primary prevention, tracking, and so forth? Could this be potentially useful in a clinical setting?
I mean, I think even before the start of the pandemic, there was a big push in clinical settings to try and incorporate patient-reported outcomes, right? There's a huge PRO movement. And I think that this app is kind of consistent with that approach, right? Trying to gather information directly from the patients and then use that information to make decisions about next steps. Who needs attention? How do you triage people based on the information that they're providing? And so I could see a potential role for this app or other apps like it as we move forward in the pandemic. I think, you mentioned telemedicine. We certainly have broken down a lot of barriers for telemedicine through this pandemic, right? I think there's been, for a long time, quite a lot of interest in telemedicine, and certainly like rural areas of the country were thirsty for it, but there were a lot of regulatory barriers. Medicare wasn't reimbursing for it. You basically couldn't get a telemedicine visit covered by insurance. And so because of COVID-19, insurance companies had to loosen these restrictions and really open the floodgates to it, and there was massive uptakes. Now, there's certainly been still barriers to telemedicine, right? There's some evidence that certain practices didn't have the infrastructure to support it. The volume of telemedicine that was required to replace inpatient visits was quite high and above the capacity for some institutions. So there's definitely a lot of infrastructure that needs to be built to it. But I would hope that seeing how successful it has been in many occasions, that is support for its continued use even beyond the pandemic, at least for certain types of care. I think we've learned that there is some care that can be provided that way. And to the extent that it brings people in that might not otherwise have been able to make it in person, it's a great advantage.
And I think, and this kind of ties in with equity too, and some of like what we said earlier in terms of using what we see with the app to think about equitable vaccine distribution. Where should we be targeting? Should we be going with mobile vans to certain communities for testing and vaccine distribution? But then also we talked about cancer and, seeing how the impact of the pandemic is going to lead to, there was a paper in Science that said about 10,000 additional breast cancer and colorectal cancer diagnoses in the next 10 years. But it's the same populations that this app and other studies have shown that have been hit hard that will also be hit hard by those, other diseases in years to come. So really thinking about, how to target those populations, not only in COVID-19, but in terms of prioritizing follow-up testing and treatment and using, the hotspots in a way from the app.
That's a great point. And how to get to patients where they are in the community with mobile vans, transportation, other things. I know it can be a major challenge. So thank you. Any other thoughts about healthcare dissemination implementation in this work? I imagine there's quite a few potential applications, but could this be used in local communities to track? Yeah.
I'm wondering about COVID itself. I think this is already said in part, perhaps, but for example, getting a handle on sort of the intention to vaccinate among different groups or geographic locations could, now or in the near future, could provide maybe a target for, educational efforts, outreach, and these kind of things.
Yeah, so we actually, Erica and Hajwa and I are on a grant application looking at trying to do an intervention just like that, where you could improve outcomes and education, basically, and using the app as a potential outcome measure. That can you reach a community and have them start to use the app, understand daily tracking of symptoms, and how important that can be, and getting testing when there's when symptoms are present. That's something we've discussed quite a bit amongst ourselves.
That was fascinating. And good luck with the grant proposal. Yeah. All right. So in terms of this work and implications for health policy, a number of structural risk factors were highlighted here. And are there thoughts about how we can translate some of this to policy now? Public health policy in particular. This could inform policy.
I think it can absolutely inform policy, and then, thinking about, again, the community level and structural factors and policies that address those factors and put money towards those factors in terms of, putting money towards education, healthcare policy, which we know is always a big topic of discussion. The factors that lead to neighborhood segregation, jobs, housing, access to healthy food options, all of those factors that lead to disparate outcomes in COVID-19, but also in other diseases and in cancer and so forth. And also putting more money in general just to the public health infrastructure, because we know that this is not the last pandemic we'll see. I hope it is, but it's probably not. And really, ensuring that we are able to appropriately respond.
Thank you.
Yeah, I think, one of the policy things we've learned and became clear pretty early in the epidemic or pandemic was what a patchwork system, healthcare system we have here in the United States, right? And some of that is by design, right? We are the United States of America. We have built into our Constitution the strong belief in states' individual rights, but I think that kind of rugged individualism that is so much of America is great in some situations and not great in others. And this pandemic has really demonstrated that it doesn't work well in this type of situation, where what we really need is coordinated action and consistent policy messaging and approach. And so I hope that one of the policy things that comes out of this is a plan for coordination, right? Some centralization that can occur as needed. Like, I get that not everybody wants it all the time, but sometimes we do need it. And as was mentioned, we need the infrastructure built so that we can work together across the country quickly and fastly.
Yeah, I would say that one of the, and to tie this back in with implementation as well, as one of the limitations in your prior question about how public health authorities are using this in real time, that's been very limited by that patchwork system that Erica just highlighted in the US. Whereas with the universal healthcare system in the UK, you can get these resources to a centralized entity that can then make this actionable information. And that has been rather challenging in the United States. We can do it in a piecemeal fashion, but even something as small as an more academic effort like this can influence health policy in the United Kingdom, but is very limited in terms of the impact to be able to turn into immediately actionable intel for public health authorities here in the US. We're constantly thinking of ways to improve that implementation, but ultimately a centralized resource like what Dr. Warner just alluded to is needed to be able to leverage this and bring all of these data tools that we have in our toolkit into under that umbrella so that we can really use it.
Yeah, and if there's an infrastructure bill in the future that could include infrastructure for structural health to deal with the neighborhood level issues and poverty and food insecurity and education, all those things that would be so needed to have some national plan that would cover that. All right, well, thank you all so much. We have one other question, which is, what are the implications for future translational research? Several were raised, Dr. Drew raised about genomics and other areas, but what are some other areas where this has future translational applications that really need to be followed up?
Yeah, so the one thing that I think keeps me awake at night is, as a normal cancer epidemiologist, if we don't capture enough data on the impact of this disease on patient populations to really understand long-term health consequences, we will miss a lot of things translationally for cancer research, other disease research for a very long time. So as a part of my other hat that I wear as the director of biobanking for the CTU at MGH, we really did also focus at the beginning on making sure that we were collecting biospecimens in a robust way across the Mass General Brigham healthcare system to be able to pair with this and also encourage individuals who may provide specimens to us to use this app regularly. And I think the real power of our tool is that we've paired this with all of these cohort studies that have deep, richly phenotyped baseline data or longitudinally collected data prior to the incidence of COVID-19. And many of the cohorts are supplementing the tool of daily tracking from COVID-19, from the symptom study, with their own questionnaires and biospecimen collection that I think will really empower us to understand not only the mechanism of COVID-19, but the mechanism of COVID-19 and potential impact on other diseases, and then also really understanding how we can better implement biospecimen collection in the next pandemic, should that arise, or under other strenuous conditions in other hard to reach populations where we still need to really address many different public health crises that will help us understand the different mechanisms of disease among different populations and in different countries. And I do think that we've learned a lot from trying to implement this rapid tool so quickly. One of the things that I jokingly said will hopefully stick around, but I'm not joking at all, is that the efficiency by which we were able to get things through regulatory bodies so that it didn't become a barrier to performing research in real time. And it was really an all hands on deck situation. It wasn't that it became more careless. It was that everybody really was able to focus on one problem. And it was really nice to see, at least internally at Mass General Brigham, but also I think what we've learned from a lot of these other institutions that we worked with is that many institutions are working on the same page to try to come together to rapidly address this problem. So if we can take those lessons and apply it to a lot of the other things that we normally study, I think it will really impact translational research and our understanding of the mechanistic basis for disease.
I'd like to give a shout out to, the materials you guys developed, like as a, the collaboration here at the Genomic Health Initiative at NorthShore, the IRB toolkit, the FAQs you guys put together made it really a breeze to go through and fairly quickly, get our own local approval. So thanks for that. I'm wondering, have you guys been discussing perhaps having a survey about plans for holiday gathering and then actual practices, and following that up with perhaps you guys would be in a great position to be able to see the effects of this or that kind of behavior?
It's a really great question. We've talked about it quite a bit. The only challenging thing is that Thanksgiving is not a national holiday in the United Kingdom. So
Right.
so implementing the questionnaires around that specific thing has become logistically challenging in terms of making it available to the appropriate app users, because we do really try to keep it a uniform platform across the countries. And every time we make a change, there's a very rigorous set of processes that we have to go through to make sure it's still secure and that it meets all of the requirements of the app stores. So we have discussed it. I don't know if we would be able to get something implemented in time. I think we were all hopeful that we wouldn't be here come Thanksgiving and Christmas and the holiday seasons of having to worry about COVID-19 so intensely. But we should be able to track that. And our hope is that we will identify trends in people's exposures using our standard questions that are there. That, how often, how many people have you interacted with? Have you stayed home? Right. Have you always worn your mask? Those social distancing measures, I think we will be able to measure that quite a bit, but I'm sure we will see spikes and peaks, especially as college students return home from different regions of the country and potentially long-term. And hopefully people are being smart about their gatherings. I know different governors and different states are taking different approaches to all of this. So again, centralized resources could really be helpful in making more universal mandates to help the public health.
Well, I just think it's extraordinary what you all were able to do in such a rapid time frame, and it's so prolific as well. So congratulations for your leadership and your humility as well. You have a lot to be proud of. All of you do, and also your work in the community that as the physicians on the call are doing. I'm really blown away by how this can happen and on that scale as well. So I thank you all so much for taking your time. Can we go to the next slide? And if there are any other comments from the panel, please, we do have some time. But okay. All right. So I'd like to thank our outstanding presenters today and panelists for taking the time for this presentation and contributing your thoughts and insights to this work in terms of disparities in the community, but also among healthcare workers, in terms of the predictability of certain symptoms that can be used to affect modeling of real-time data, and in terms of really highlighting the areas where we can identify hotspots and hopefully inform policy and and practice to better prevent hotspots and at-risk communities. So for questions for the participants, concerns, requests to present at a future seminar, please contact me directly. My email is listed here. If you could all please take a brief survey regarding today's presentation, that would be appreciated. You'll be directed to a site after you close out the window, and the link is also in the chat box. Our next seminar will be on December 15th at 3 o'clock. Dr. Richard Novak from the University of Illinois at Chicago will be presenting his work on COVID-19 vaccine research. And lastly, the recording of today's webinar will be distributed in a few days. Thank you again, and have a great rest of your week. Francesca?
Thank you, everyone. I'm going to share my screen with the link. If you could all take a moment after the seminar to take a brief survey.
All right. Okay, and again, to Dr. Drew and the panelists, this was wonderful. Thank you so much, and we look forward to future correspondence as the story continues.
Thank you very much for the invitation.
Thank you.
It's our pleasure. Thank you
for having us.
Oh, it's a privilege.
Thank you so much, everyone.
Thank you so much. Thank you.